One of the unmet needs that we saw was, first of all, the standard of care is a serum creatinine test. We've been around for what feels like 100 years, but it's not that specific. It's not that sensitive to the clinician's needs. It's a good general test, but it's a little old-fashioned. Or a biopsy. And the biopsy is the gold standard. So that's when they go and take some tissue out of the organ. Very invasive, comes with risks. We are very close to a patient that refuses ever to have a biopsy again because of the complications after her last one. So it comes with problems. And it also is, called the gold standard. We call it a bronze at best standard, because if you think about it, it's a very, very small part of the kidney. If you get it into the wrong area and you haven't picked up, the damage, you think it's okay, but it's not. So it's a bit hit and miss about whether you've got the right area. But still, it gives you the most information, and still, we would say it's the standard of care. But you don't want to be doing it all the time. And clinicians are faced post-transplant with this very delicate balancing act. On one hand, they're trying to manage rejection. And the way that they do that is they give what we call immunosuppression drug therapy. Suspends the entire immune system. You can imagine it's a big therapy. On the other hand, that then opens the patient to infection, complications from the drug toxicity, but also cancer. So they're playing this balancing act. They want to give enough of that drug so they don't have rejection, but not too much that they cause all of this other problems. And so if you think about it from the clinician's point of view, they want to have good information about their patients, but biopsy is not the answer.